Mallory Weiss tears are mucosal lacerations at the gastroesophageal junction, often caused by forceful vomiting or retching. Let's discuss the key points in their management. Patients often present with hematemesis, vomiting bright red blood, or coffee ground emesis. Symptoms may follow episodes of alcohol consumption, excessive vomiting, or severe coughing. Be alert for signs of hypovolemic shock, such as tachycardia or hypotension. The gold standard for diagnosing a Mallory Weiss tear is upper gastrointestinal endoscopy. This reveals the longitudinal mucosal tear, usually on the gastric side of the gastroesophageal junction. Endoscopy also helps rule out other causes of upper gastrointestinal bleeding, like peptic ulcers or esophageal varices. Start with 4 fluids to stabilize hypovolemia and maintain hemodynamic stability. Administer packed red blood cells if the patient's hemoglobin is critically low or if there is ongoing bleeding. Use proton pump inhibitors to reduce gastric acidity, promoting clot stability and mucosal healing. Antiemetics may be given to control nausea and prevent further retching. If bleeding is active, endoscopic intervention is the next step. Techniques include injection therapy with epinephrine to induce vasoconstriction, thermal coagulation or electrocoagulation to seal the bleeding vessel, and hemoclips for mechanical closure of the tear. In rare cases of persistent bleeding despite endoscopic management, consider angiographic embolization of the bleeding vessel or surgical intervention, although these are last resorts. Most Mallory Weiss tears resolve spontaneously or with conservative management. Endoscopic therapy has a high success rate with minimal complications. Advise patients to avoid triggers like alcohol or excessive vomiting to prevent recurrence. In summary, the key steps in managing Mallory Weiss tears are prompt diagnosis, stabilization, and effective endoscopic treatment for active bleeding. Understanding these principles ensures optimal patient outcomes.